So I'd like to start this session off, if we could. We have two more talks this afternoon in this imaging session, and the first is by Michael Bennett, who's at the Biomedical Research Unit at the hospital, and he's going to tell us about a number of different modes of imaging, I think, and,
yes.
And about how we can start to combine modes of imaging to produce useful things. So,
yes. Well, thank you very much. That's an excellent introduction. As I said, I'm a senior research scientist in image processing from the Biomedical Research Unit here in Southampton. So we're based at the General Hospital. We work very closely with clinicians from the hospital and also academic staff from the university as well. So we're truly a multidisciplinary research department. I'd actually like to start my talk with a quote. This is a quote from Bill Gates from his 2013 annual letter from the Bill and Melinda Gates Foundation. And he said that in the past year, I have been struck again and again by how important measurement is to improving the human condition. You can achieve amazing progress if you set a clear goal and find a measure that will drive progress toward that goal in a feedback loop. And I think that's quite a thought-provoking thing. Essentially, as I see it, what he's saying is if you have a problem, you need to be able to measure the problem in order to develop solutions. If you can't measure the problem, how can you develop a solution? In the field of lung disease and lung research, that's really quite relevant. One of the biggest problems for the development of new drugs to treat quite common lung diseases is our ability to measure whether the drug is being effective or not. And that's actually one of the big hold-ups, really, for some pharmaceutical work that's going on at the moment. So with that thought in mind, we'll move on. Considering the actual problem, these are statistics from the Office of National Statistics, from the cause of mortality rates in 2010, which I just wanted to put up as the first two, perhaps the circulatory diseases and cancers, blue and red, perhaps what you'd expect. But the third largest cause of death in 2010 was respiratory disease. And so respiratory disease is a really big problem and a growing problem, projected to become a much bigger problem in the future. So it's very important that we do work to develop new technologies and new ways of being able to measure the state of health or disease inside the lung. So how do we actually go about doing that? Thinking about tying the two previous slides together. At the moment, the principal ways of measuring lung disease would be with pulmonary function testing or lung function tests. And these are largely based on measuring how much a person is able to breathe, how much the volume of the lungs is, and all that kind of thing. But the trouble with this is it gives us only really a global measurement. It gives us one number that represents whether, one number for the state of health or disease for both of the lungs. And it can't give us any kind of localized measurement. And okay, it's certainly very effective, but... Oh, thank you very much. Yes. Oh, that's probably better. It will work well for the animations later. So it's certainly an effective measurement, but it can't give us any kind of localized measurement. It doesn't really help to say where disease might be or anything like that, which would make it very difficult to actually use it to accurately measure progress of a disease, or it would limit its ability to measure how well a new pharmaceutical is working. Imaging, this allows us to give spatially localized measurements, so we can start to actually see where in the lung a disease is having its effect and where a pharmaceutical might be working. So that's obviously quite a lot better. In terms of actual imaging technologies, perhaps the most common that would be used would be the standard chest X-ray, which would just give you a plain image. That's pretty good. But then also people are using high-resolution computed tomography as well, which I'm going to talk about a bit more later, which is able to give a great deal more detail. But the key thing about all of those is that generally the images are read manually by a radiologist. So we're very much relying on the radiologist's expertise and to some extent opinion on the state of the disease. And that's a serious limitation if you're trying to track a disease over time or something like that. If you've got that kind of inter- and intra-operator variability, it's going to affect your ability to make those sorts of measurements. So we're very interested in developing new quantitative ways of measuring lung disease using existing and also quite new imaging technology. The Southampton Respiratory Imaging Group, of which I'm part, which interfaces between the BRU and the university, As I mentioned before, we're very intrinsically multidisciplinary, so there's myself and Professors John Fleming and Joy Conway, perhaps the core team, and then Dr. Tom Havelock is a clinical research fellow that we work with as well. And we collaborate with quite a wide group of people within the hospital and also within the university, as you can see from the list there. And we also have collaborations with a number of industrial partners as well, I mentioned just there at the bottom. So spanning a wide range of people from academics, physicists, people from nuclear medicine, and the whole spectrum. So what do we actually do? Principally my work at the moment really revolves around the creation of software and algorithms to allow us to develop quantitative measurements of lung disease. So that includes developing algorithms actually to do the quantification, developing software to handle the management of data from the clinical trials that we're involved with. We're involved with functional imaging. I'll talk a bit more about some of these later on. This is just a bit of a whistle-stop tour of everything that we do. So functional imaging allows us to look at how the lung is operating, how compounds are cleared from within the lung. Working with various different measurements that we can use to measure how far a pharmaceutical or a compound has been inhaled into the lung. That's really important from the point of view of drug delivery. Actually, sort of pulmonary drug delivery is one of the more exciting avenues at the moment for pharmaceutical research, not just for lung disease, interestingly. I've heard people predict that the next generation of painkillers could potentially be an inhaler-based device rather than tablet-based, which would obviously be a lot quicker. You could then have a painkiller that would work in seconds rather than 10 or 15 minutes. So we work on technologies to measure clearance of compounds from the lungs, the division of the lung into different regions that allows us to measure clearance or drug deposition by different region. Again, as I say, I'll talk about some of these later. And we also develop advanced software tools that help us to analyse the lung in greater detail and to produce more accurate and more reliable measurements of various parameters that would reflect the disease state of the lung. And we also work with 3D functional imaging. This is a volume-rendered ventilation scan, shows the distribution of radioactive gas, an isotope of krypton actually within the lung. I'll talk about that a bit more later. And we've also developed algorithms that allow us to automatically divide the lung into anatomically defined regions based on the actual lung anatomy. So these are patient-specific divisions of the lung into finer regions. So the techniques like that then allow us to make measurements of lung function or of lung disease on anatomically defined regions, obviously that are smaller than the whole lung. And this goes back to the concept I said at the beginning with lung function testing, just gives you the one number for both lungs together. So using techniques like this, we're able to get a higher resolution, if you like, of measurement to actually measure how the disease is varying spatially throughout the lung. That's the same thing in 3D, and there we go. So in terms of imaging modalities and the kind of equipment that we use, courtesy of the Biomedical Research Unit, of which we're a part here, we're very lucky in that we have 2 dedicated research bronchoscopy suites, and we use these for the more invasive form of non-invasive imaging that we're involved with. So you see here, this is a bronchoscope which is inserted through the nose, goes down into the lungs, and allows us to create pictures. We can take videos and things, so you can see what's going on in the lungs. Apparently, it's quite common for children to inhale Lego bricks and things like that, and this is never happened to me, but this is the kind of technology that is used to find such an obstruction and to remove it if necessary, and that kind of thing. It also, the bronchoscope also contains a working channel through which we can put other instruments, so we use this to take samples from within the lung. We use it to do bronchial lavage. We wash out a region of the lung to collect the cells. And we can also use it with a technique that I'm going to talk about later called probe-based confocal laser endomicroscopy that allows us to take microscope images from inside the lung of a conscious patient, which is quite cool. But we'll come back to that. We also use high-resolution computed tomography. That's a HRCT scanner there, which I'll talk about in a minute. And we do functional imaging with a research-dedicated SPECT CT machine that we have on site. So we're fairly well equipped to do a broad range of research, and we're certainly involved in quite a range of clinical trials. So the title of my talk was Lung Imaging from Macroscopic to Microscopic. I believe it might be the other way around in the programme, but apologies. So in terms of macroscopic imaging, the larger scale imaging, I just really want to talk about HRCT. I'm conscious about not going on for too long, so I'm going to keep it fairly brief and an overview. So high-resolution computed tomography, this is perhaps maybe the most familiar of the lung imaging techniques. It's essentially based on the same technology as a planar chest X-ray. So this is the HRCT machine. Patient lies here. This is me, if you can't tell. And inside the donut shape here, we have an X-ray source. We have a number of sensors here, and the X-ray source beams the X-rays through the patient, and that creates an image on the bank of sensors. And then the whole system rotates around inside the gantry incredibly quickly, and actually seeing one of these operating without the covers on is truly terrifying. But thankfully they're there, otherwise nobody would go in one. And the whole system, it rotates continuously as the patient slides through slowly on the bed and is able to develop, therefore, a full scan of the chest. And in fact, it works incredibly quickly. We can do an entire chest scan in around just about 10 seconds or so, easily within one breath hold, which is important for lung imaging. Obviously, the lungs are quite dynamic and move around, and for imaging, it's better if they don't. So we instruct the patients usually to hold their breath for such a scan. The kind of results that we get from that look something like this. So we get a tremendous amount of information from a HRCT scan. I'll talk about this in a moment as it plays. But one of the challenges that we face is actually coming up with a way of making sense of all of that information. It's something you know all about, yes. Normally, for kind of clinical HRCT scans, they use a relatively small number of slices in particular locations throughout the thorax, because the images are read manually by a radiologist. For something like this, for a kind of HRCT scans that we do, we get between 600 and 700 slices across the height of the chest, depending on the height of the patient, which would obviously be far too much for someone to go through and read manually. So a lot of our work is focused on developing tools and algorithms to allow us to automate as much as possible the process of making measurements from this kind of data. And just to talk about the data a little bit, this is the heart here. You can see the vertebrae, structure of the spinal cord. You can see a great deal of structural information within the lungs themselves. That's the two dark regions. This is the diaphragm here, so just at the bottom. And you can see some of the stomach here. And we'll come back up. So this is the right lung. This is the left lung. And we can see these bright regions. These are the pulmonary arteries and veins within the lung. And as we get towards the middle, you can start to see some of the airways, and these coalesce into the right and the left main bronchi, which then come together into the trachea, which is the structure that comes up to your mouth. And you see details here of the shoulder blades and other muscle and other tissue going on there. So a huge amount of information. Perhaps a better demonstration of actually how much information we get from the lungs is this. Now, this animation is made from actual CT data from one of our study participants, and it shows the left and the right lung, and we have the trachea and the left and the right main bronchi shown in grey. And you see the level of detail that we're able to see, particularly if we fade the lungs out so that we see what's going on in the inside. We can see that we're actually able to detect the airway tree very reliably, and we can get down in a healthy patient down to the 6th or possibly 7th branching generation. So that's down to airways that are just under 2 millimeters in diameter, which is pretty impressive. And we have a variety of software tools that we use to analyze this kind of data, including commercially available packages that are able to actually take that airway tree segmentation and then take measurements of all of those airways. So we look at things like the airway wall thickness, the branching angle, the length of the airways, all of these things. So it gives us a tremendous amount of information about what's going on in the lung, and a great number of variables that we can look for, for correlations with other measures of disease. And we're also involved in work to develop new algorithms as well to process this kind of data and use this kind of information to divide the lung down into anatomically relevant regions and that kind of thing. So in terms of disease, I just wanted to show just really one example of the kind of differences that you might see in the lung on HRCT between health and disease. Now this is for a specific disease. This is for a subject with emphysema. That's quite severe, moderate COPD, chronic obstructive pulmonary disease, a large component of which is emphysema. So just to explain, this on the left here is a healthy subject, and on the right is the disease subject. So in the healthy subject, if you look at the space inside the lung, you can see that it has fairly uniform texture. It's not completely dark, it's not completely light. It's got a particular texture, a particular pattern, and that's quite important. So this is the trachea, sorry, just to say. and this is the left main bronchus, the right main bronchus. These are the airways and the pulmonary vessels and things going on. If we compare that image to the one on the right, you can immediately see the difference. So here, this is the upper lobe here, the right upper lobe and the left upper lobe, you can see a very much darker than the lower lobes, and that's because they've been affected by emphysema. Emphysema as a disease process results in the destruction of the lung tissue, starting out at the alveoli, the very smallest components of the lung tree where the gas exchange takes place. And the tissues break down and it results in air spaces forming and a process actually called gas trapping. And that shows up as dark regions on the CT because it's much lower density, so you can tell that. But the key thing I really want to show with this is that the material inside the lung on the HRCT shows up as having a specific pattern or texture. And part of the work we're doing in collaboration with the School of Electronics and Computer Science is to develop new technologies for looking at this texture as a way of trying to detect this kind of disease process earlier. The problem with diseases like emphysema is that they're progressive and actually quite an insidious disease, because by the time you can detect that someone's got it with pulmonary function testing, it's already quite well advanced. It would obviously be a lot better if we could have techniques that would allow us to diagnose the disease earlier. And so we're working, hopefully, to develop techniques that will allow us to pick up the changes in the pattern, in the texture of the lung material before it gets as bad as this. Okay, so functional imaging, you could think of this in a sense as moving down in scale from macroscopic, sort of crude, or not crude, but some anatomical imaging that we've got with the HRCT gives us a great deal of information about the anatomy and the structure of the lung. So functional imaging allows us to actually look at how the lung is operating and how the different processes are going on, how well it's actually doing what it's supposed to do. Excuse me for a moment. Okay. Most of the functional imaging that we do using either planar gamma cameras or SPECT, or single photon emission computed tomography imaging. What all of these have in common is that we use radioisotopes to label a compound, or we use a radioactive gas. In other words, we get a radioactive compound into the lung, and then using the gamma camera or the SPECT machine, we're able to image the pattern of that radioactive activity within the lung so we can see where it is. So these example images here, this is from a clearance study. So we've used a radio-labeled compound that the subject has inhaled, and it's deposited within the lungs. You can see within the lungs here. You can actually see the shape of the lungs really quite clearly in this case. And there's some deposition in the stomach as well, and you see the activity left over in the trachea. And what we're looking at here is how quickly that activity is cleared out of the lung. Now, the airways within the lung are lined by a ciliated membrane, so the cells have small hairs, and they, in health, all beat in a particular sequence, and that results in a clearance of the natural mucus lining on the insides of the airways. And this is the lung's natural mechanism for clearing any foreign bodies or small foreign bodies that might be inhaled. Now, quite obviously, that process could be interrupted by disease, and so we're looking at ways of improving how much we can quantify the rate of that clearance in order to look at how we can use that to relate to lung diseases. So these images show essentially clearance over time, so after 12 minutes, 47 minutes, and 1 hour or 2 hours there. You see, particularly if you look at the scale bars, you can see that a lot of the activity has been cleared out. And we also do 3D functional imaging using single photon emission computed tomography, or SPECT. This is a SPECT machine here. This has 2 gamma cameras on either side of the patient, and they rotate around in exactly the same principle as for the high-resolution computed tomography. And that allows us to build up a 3-dimensional image of the distribution of activity within the lung. That will work. There we go. So this is the kind of data we get for that. You see on the left, we have the CT. This is actually a low-dose, low-resolution CT scan with the ventilation and perfusion data overlaid. So I should explain, this is ventilation measured with the inhalation of an isotope of krypton gas, or krypton-81 gas, which shows up in here in yellow. And perfusion, we used an injected radioisotope to measure how much the blood was perfusing into the lung. So in health, the ventilation and perfusion should be equally matched. If there's a mismatch, or they are both quite low, then that indicates that something's wrong. They're also developing techniques for the visualization of this kind of data in 3D. So this animation here, this shows a volume rendering of the three-dimensional distribution of just the ventilation-only data for the same subject. This is a healthy subject, which means that we're quite you can quite easily make out the shape of the lungs, even the trachea, and the left main bronchus shows up there as well. The problem with functional imaging on its own is because we're imaging where the gas has gone to in the lung. If part of the lung isn't working, if one of the airways is blocked or something like that, or we've got gas trapping going on like we saw in the CT, then the gas isn't going to get there and we're not going to get any data from that. So although in the healthy example here we can quite clearly see the shape of the lung from the functional imaging, we can't assume that that's always going to be the case. If we're looking at someone that's diseased, it could well be that the upper lobes would be completely missing. So what we need is techniques that would allow us to combine the anatomical information from the HRCT with the kind of functional imaging that we get from the SPECT. And that's a big area of the research I'm involved with at the moment. Just as a quite clearer example perhaps of what I'm talking about, so these are two-dimensional slices through the three-dimensional data that we've just been looking at. For a healthy subject here, we see the ventilation in yellow and perfusion in blue as before, and we can see for the healthy subject the ventilation and perfusion is very even and uniform throughout the lung. In the subject with the moderate emphysema, and this is the same subject we saw the example for with the HRCT earlier, we can see the upper lobes here in the right and the left lung have much less ventilation and perfusion than they do in the health or indeed in the lower lobes. So quite clearly, if we were try to delineate the shape of the lungs from this, we would really have a problem. So we need to have some way of combining high-resolution CT with the SPECT data. So this is just really a brief example of the kind of work that we're doing in that area. So here, on the left, we have ventilation SPECT data shown in two planes, the sagittal and coronal planes through the lung. And here on the right, we have anatomical regions. These are actually the bronchopulmonary segments. I won't go too much into those, which are being derived from the lung anatomy, which we've measured from the HRCT scan. And in the center, we can see the results of combining these. And perhaps this makes it look quite simple, but this is a very non-trivial task to actually combine these together, because the high-resolution computed tomography is done while the subject is holding their breath, because we can do a scan in 8 seconds typically. For the functional imaging, it takes 15 to 20 minutes to do the scan. We can't really ask someone to hold their breath for that long. So obviously the lungs are moving, and this results in quite a significant change in the shape of the lung, and it's all a very dynamic and complex process. So we've developed non-rigid registration methodologies that allow us to achieve this result, which is quite exciting. And this allows us to perform now measurements of the ventilation and perfusion, or even aerosol deposition or drug deposition, on a regional basis. So we can identify small anatomically relevant regions of the lung and say this region was affected by this much and this region by this much. So again, we're getting down to that finer scale of measurement from the very crude measurement from pulmonary function testing, the single number from both lungs. We're now down to being able to actually say not just within one lung, but within one region of one lung, how much the disease was affecting that area. Okay. So the final section I want to talk about is microscopic imaging. I mentioned briefly when I showed the slides showing the bronchoscopy suite that we were doing a technique called probe-based confocal laser endomicroscopy. This is a very new imaging modality. To the best of my knowledge, we're one of only 5 centres globally that are applying this technique in the lung. So we'll have a look. So this technique is done during bronchoscopy, which I mentioned, and I mentioned about the bronchoscope going in through the nose. I just wanted to show an example, actually, of what you see during a bronchoscopy. So what we see here, these are the vocal cords. They've gone, that was too quick. Let's go back. There we go. We see the vocal cords here, and we're going down between the vocal cords. This is a local anaesthetic has been used. This is, but that's all. So this is a conscious patient. And this is the inside of the trachea, which is quite interesting. You can see the cartilage rings that keep it stiff. And this is the going down into the right lung and the left lung down there. And the doctor that was doing this is going to put the bronchoscope down here into the right lung. So the bronchoscope has a working channel through which we can insert other instruments. Now, the PCLE, or probe-based confocal laser endomicroscopy machine that we use, is essentially a confocal microscope with a 1 millimeter diameter bundle of optical fibres attached. I think something like 16,000 fibres or something like that. And it allows us to get microscopic scale images from inside a conscious patient. Let's give you an example of that. So this video will show, let's play it, here we are. So this is an example of the results we get from the PCLE. See the scale bar here, there's 50 microns there. And what we're looking at here, these are actually the elastin fibres that form the opening of the alveoli duct. So this is right down at the very end of the airway tree. This is where, in the lung, the gas exchange actually happens. This is the business end of the lung, if you like. And this is using a laser of a wavelength of 488 nanometers, so it causes autofluorescence in elastin fibres, which is why they show up. But what's very interesting is these blobs, and these sort of blob regions which you can see moving about. These are macrophages. These are the cells that go around within the lung, actually cleaning up things that shouldn't be there. And what's quite fascinating is this subject was a smoker, and the reason that the macrophages show up is because the nicotine compounds from the smoking also autofluoresce under the laser light that we use. So it's curious, I don't have an example on here of a healthy patient, but if you compare, or a non-smoker, sorry, if you, if you compare to a non-smoker, you don't see the macrophages. And that's not because they're not there, it's simply because they're not lighting up in the same way. So I think that's quite exciting. We're able to get that kind of image live. This is 12 to 15 frames per second from inside a conscious patient. You can talk to them while you're doing this procedure sometimes. Some of the hardier ones anyway. You wouldn't believe how much vomit a human adult can contain. Anyway, just to say about quantification then, because really the whole purpose of this really, of my talk, is to say about quantifying the disease. This is PCLE imaging, the same thing we've just been looking at, but from a different region of the lung. This is actually from the right main bronchus, one of the large airways. And we have a healthy example here on the left and a diseased example here on the right. And what we're looking at, these are the elastin fibres that make up the structure of the airway wall. And certain disease processes, such as asthma or indeed emphysema, will cause airway wall remodeling. So they cause damage to the structure of the airway wall, which will then heal itself. And in health, all the fibres are really nice and straight and parallel and regular and ordered. And in disease, they become much more disjointed. And we have, working on and have, developed algorithms that actually try to quantify the extent to which this is happening. So by using image processing techniques that we've created, we're able to identify the actual elastin fibres. Here, the healthy example, and here on a mild COPD example, and you can really see what I'm talking about, the difference in the structure. And if we look at the distribution of the angular directions of all of those lines, the difference is really clear. So this is a directionality histogram, shows the angle of the lines for the healthy example, and we see we have a very narrow peak. And in the disease case, we have a very broad peak, a really clear difference. So this is one of the more exciting areas of work that we're involved with at the moment. Okay, thank you very much for your attention. Any questions? Happy to talk.